Hello, everyone. Thank you for joining today's 2021 MIPS Quality and Cost Performance Categories webinar. During today's webinar, CMS will provide an overview of the quality and cost performance category requirements for the 2021 performance period of the Merit-Based Incentive Payment System, or MIPS. After the presentation, CMS will take questions as time permits. Now I'll turn it over to Dan Herman, a health insurance specialist at CMS, to begin.
Thank you, and thank you everyone for joining today's webinar on the quality and cost performance categories of MIPS for the 2021 performance year. We're excited to have various CMS subject matter experts on the call to give you an overview of how to participate within these performance categories and collect data for your work. Next slide, please. This slide shows our normal disclaimer, which is a reminder that today's presentation is a tool to assist participation in the quality payment program and not a legal document. For official Medicare program provisions, we encourage you to visit the relevant laws, regulations, and rulings for the latest policy changes. Next slide, please. Today's presentation will begin with a brief overview of the quality payment program and the Merit-Based Incentive Payment System, or MIPS. I'll then turn it over to Dr. Green and Zenobia Raspberry to discuss the quality performance category before Dr. Jesse Roach provides details on the cost performance category. There will be time for a questions and answers session following our presentation. You can submit your comments or questions through the chat box at any time. Please note that we are also going to schedule a second webinar to discuss the improvement activities and promoting interoperability performance categories in the next few weeks. More information about this will be announced through our listserv. Next slide, please. Before we get started with today's presentation, I wanted to provide a brief update about our continued response to COVID-19. We're well aware of the impact that the COVID-19 public health emergency has had on clinicians nationwide. So we have again issued our extreme and uncontrollable circumstances policy for clinicians who want to file an application for the 2021 performance year. For MIPS eligible clinicians, groups, virtual groups, and APM entities unable to participate in the MIPS program because of the COVID-19 public health emergency, this policy allows them to submit an application for reweighting one or more performance categories. The application will be available on qpp.cms.gov, and you'll need to select COVID-19 as the reason for reweighting. The Extreme and Uncontrollable Circumstances application will be available on our website very soon, and we'll make information available through our listserv when it's released. We encourage you to sign up to our listserv on our website at qpp.cms.gov. Next slide, please. Now we'll provide a brief refresher of the quality payment program. Next slide, please. The quality payment program was authorized by the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, which required CMS to implement an incentive program. QPP consolidated three of our previous legacy programs: the Physician Quality Reporting System, PQRS, the Medicare Electronic Health Record Incentive Program, and the Physician Value Modifier, VM. Now, there are two participation tracks to QPP: the Merit-Based Incentive Payment System, which we refer to as MIPS, or Advanced Alternative Payment Models, or APMs. Within MIPS, clinicians are subject to a performance-based payment adjustment. If you participate in an advanced APM, you may be excluded from MIPS and eligible to earn a lump sum incentive payment if you meet certain thresholds. As mentioned, today's presentation will focus on two performance categories within the MIPS track of the quality payment program. Next slide, please. Finally, I'll provide a brief overview of MIPS. Next slide, please. As you may be aware, MIPS assesses clinicians' performance under four different performance categories: quality, cost, improvement activities, and promoting interoperability. This slide shows how each performance category is weighted to create your MIPS final score for traditional MIPS. Quality is 40%, cost is 20%, improvement activities are 15%, and promoting interoperability is 25%. Note that we revised the weights for quality and cost this year. Both quality and cost will be set at 30% in the 2022 performance year as required by law. For the purposes of today's webinar, we'll be focusing on the quality and cost performance categories of MIPS. Again, we're going to schedule a second webinar to discuss the improvement activities and promoting interoperability performance categories in the next few weeks. Next slide, please. It's important to note that we define a MIPS eligible clinician based off of their unique TIN NPI combination. For those who may not know, a TIN is a tax identification number and an NPI is a national provider identifier. The TIN NPI combination helps us determine whether or not someone is eligible or otherwise excluded from the MIPS program. We encourage you to refer to the participation status lookup tool on qpp.cms.gov for information about your particular status. Finally, the 2021 performance year runs from January 1st, 2021 to December 31st, 2021. Data submission will follow in the first quarter of 2022, and we then issue feedback later in 2022. Payment adjustments will be distributed in calendar year 2023 for 2021 performance. Next slide, please. Now I will turn it over to Dr. Daniel Green to provide more information on participating within the quality performance category for the 2021 performance year.
Thanks, Dan. Appreciate the great overview. Can we move on to the next slide, please? Okay, so we're going to talk about some of the basics of the 2021 quality performance category. As many of you may recognize from the PQRS days, which was the legacy program that the quality portion of the MIPS program was partly based on, this category is going to assess the quality of care clinicians deliver. And again, we use the quality measures to help us do that. The quality measures can measure healthcare processes, outcomes, patient experiences of care. We hope that the measures are linked to outcomes. In fact, that's our preferred type of measure. However, we also recognize there are other measure types that are important. The measures themselves, though, all need to be linked to either show effective care being given, safe care given to the patient. The measures we hope to be patient-centered, so very relevant and important to the patient. Healthcare equity is an important consideration when we look at measures, and of course, providing timely care is also important. Next slide, please. So I think Dan mentioned this. For the 2021 performance year, the quality performance category accounts for 40% of the MIPS final score. It is, however, 50% for MIPS eligible clinicians who are participating as an APM entity, so a little difference there. And I think, as Dan also mentioned, in 2022, this will go down to 30% of the MIPS final score for people participating in MIPS. The reporting period, so the time that the measures are collected, would be January 1st through 2021 through December 31st of 2021. So it is the full calendar year. Next slide, please. As you can see from this slide, there are over 200 MIPS quality measures. Can be a little daunting in trying to pick out which measures you want to report on. And as a result, we have tried to list them by specialty sets. Doesn't mean that if you're a particular specialist, you're restricted to participating or using a measure from your specialty set. So if you're a surgeon, you don't have to use a measure, for example, from the surgery specialty set, but it's intended to be a tool to help drive you to measures which may be most applicable to you. So I digress here for a minute. Did want to talk about the MIPS scoring policies and which emphasizes and focuses on high priority measures. Again, different measure types would include outcome measures. This would include things like intermediate outcome measures and patient-reported outcome measures. Intermediate outcome measures would be something like measure number 1 in our program, which measures glycemic control for diabetics. So it's a hemoglobin A1C measure. And basically, we call that an intermediate outcome because we know that if patients, diabetic patients whose glycemic control is better, will likely have fewer downstream effects from lifelong diabetes, less kidney disease, less heart disease, just as 2 examples. So in this case, we're using the hemoglobin A1C as a proxy for hopefully improving the patient's outcome in the future by having fewer diabetes-related issues. In any case, we also look at measure types that include appropriate use. So, did you get a test at the proper time on a patient, who came in with a particular symptom? Or did you get a test which really isn't recommended, like getting an MRI immediately after a patient comes in with back pain, obviously depending on, the associated symptoms with it, but just speaking in general terms. Prescribing antibiotics when the patient may have a viral condition. Other important measure types include patient engagement and patient experience of care. Patient safety issues, of course, is of paramount importance. Care coordination is extremely important and considered a high priority measure for us, as well as medications related to overprescribing or monitoring patients who are on opioids. And then, of course, efficiency measures. Next slide, please. Okay, so this is a little bit of a busy slide, a lot to read here. But again, this kind of just helps to define the different measure types, and we kind of talked about these on the previous slide. Certainly the intermediate outcomes, I think outcomes is pretty straightforward. Process measures are things like, did you get a mammogram or did the patient have a colonoscopy? Obviously quite important, but it's did you do X, Y, or Z? Did you give the patient a flu shot, for example? Patient-reported outcome measures, again, these are going to be reported by the patient. The CAP survey is an example of a patient-reported outcome. So structural measures give consumers a sense of the healthcare provider's capacity, their systems, what they have in place. We don't have a measure that says, do you use EHR specifically? But, that would be a structural measure. It's a kind of a yes or no, one time during the reporting period. Patient engagement and experience measures. Again, this is direct feedback from patients and their caregivers about the experience they're receiving. CAPS could fall under this too. I misspoke before about the patient-reported outcomes. That's going to be more toward, I had a total knee replacement and my pain or function is improved by X%, for example. The patient engagement experience would be a better example of the CAPS measures. And then efficiency measures, of course, are going to assess the variability of the cost of healthcare. And again, with an effort to make healthcare more affordable. Next slide, please. So this slide, hopefully you all, or at least have heard of the phrase Meaningful Measures Initiative. And what we're trying to do is we're trying to incrementally remove process measures in an effort to move toward more meaningful measures for patients and more robust quality measures. So not simply, patient came in and I did this, it's a checkbox measure, but we're looking to try to tie measures more toward outcomes or patient experience, things that are going to be more meaningful for patients. Before we remove a measure, however, we do give consideration to whether the removal process impacts the number of measures available for a specific specialty. So if a specific specialty only had 2 or 3 measures, if we remove one, how's that going to affect them and their ability to participate? We also look to see whether the measure addresses a priority area in the measure development plan. Again, whether the measure promotes positive outcomes in patients, we do give consideration and evaluations to the measure performance data. So if we're having a measure that, the clinicians who are reporting it are performing 99% of the time, that measure is probably topped out, and there's probably, generally speaking, not enough of an opportunity to move the needle, if you will, on those measures, and those measures would be considered for subsequent removal. Again, we try to keep high priority measures. We kind of talked about that a little bit. We do look at measures that have low reporting rates for 2 consecutive performance periods. So if people are not using the measure, we don't want to have measure bloat where we just have measures in the program for measure's sake. Obviously, we want them to be used and drive quality. At the same time, measures that have low reporting rates may not be able to be benchmarked if we don't have at least 20 providers or groups submitting on at least 20 instances. So measures that can't be benchmarked for 2 years or more are considered as well for possible removal. Next slide, please. So telehealth is a very popular topic with the pandemic. And we know that it's impacted clinicians' ability to perform certain patient-facing encounters. Telehealth codes have been added to some quality measures, obviously where appropriate. You can't do a colonoscopy by telehealth, unfortunately for the patient maybe. But that notwithstanding, we have tried to add telehealth codes where it makes sense in the measure. Obviously, when you're considering using a telehealth code, you should, of course, double-check the measure specifications to see whether telehealth codes are permitted, and, of course, if it makes sense. You can review the 2021 MIPS quality measure list, again, for additional information on this topic. Next slide, please. Okay, so I'm going to spend literally 2 slides on talking about reporting overview. So next slide, please. So to complete the reporting requirements for the QPP quality category, you can report on at least 6 MIPS quality measures, one of which needs to be an outcome measure. If there's no outcome measure that's applicable to your practice, you can report on another high priority measure. And again, we talked about those high priority measures earlier in the presentation. You can also report on a defined specialty set. So some specialty sets, not many, but a few, have fewer than 6 measures. If you report on all those measures in the specialty set, again, that have less than 6 measures, you will meet the quality reporting requirements. By the way, specialty groups are not limited to reporting a defined measure set. If you are using the web interface, so you need to report on all 10 required web interface measure. So that option is available to groups, virtual groups, and APM entities with 25 or more clinicians that register in advance, which would be April 1st through June 30th of the submission period. Registration is not required for Shared Savings Program ACOs reporting on the web interface as part of the reporting requirements under the APP. Please note that the web interface will sunset starting in the 2022 performance period. So after this is the last year of the web interface. Next slide, please. So spend a second to talk about different collection types. So a quality measure can be collected in multiple ways, but each type has its own specification or instructions for reporting. So, for example, an electronic clinical quality measure may not exactly mirror the claims quality measure version of that measure. Part of this has to do with implementation, logic, etc. There's a host of reasons why they are not 100% identical. The intent of the measure, however, is the same, and we do encourage people to please check the specifications for the method of submission that you'll be using. We do use separate benchmarks, so claims are not a claims benchmark may be different than an ECQM, an electronic clinical quality measure benchmark. And you can see with these hexagons the different types. There's the electronic clinical quality measures, or ECQMs. There's the MIPS clinical quality measures, which are generally reported by third-party intermediaries such as registries and QCDRs. Then there are qualified clinical data registry measures. So these are measures that are submitted by a qualified clinical data registry that's been approved by CMS, and their measures have been vetted. So these are measures not generally available or included in the 200 plus that I mentioned earlier. These are additional measures that specific QCDR, and to the extent that they license them to other QCDRs, can report. People can submit their data through Medicare Part B claims measures, but this is only available to small practices with less than 16 clinicians. So again, if you're a large group, you cannot use Medicare Part B claims. There's the web interface, and again, this is only available to the Shared Savings Program ACOs and other pre-registered APM entities or groups or virtual groups with 25 or more clinicians. And then, of course, there's the CAHPS for MIPS survey. They would submit the CAHPS data, and this is only available to pre-registered groups, virtual groups, and APM entities. Next slide, please. So I want to just spend 1 minute talking about the 2 new MIPS quality measures that will automatically be evaluated and calculated through administrative claims. So by using administrative claims, there's no reporting burden experienced by the clinician or group. These 2 measures include the hospital-wide 30-day all-cause unplanned readmission rate for MIPS. And this is replacing the all-cause readmission measure starting this year in the 2021 performance period. The other measures, the risk standardized complication rate following elective primary total hip arthroplasty and or total knee arthroplasty, again, also for MIPS. And again, these are measures that do not require reporting on the part of the clinician. Next slide, please. Okay, so this last slide that I'll be covering just looks at submitting quality data. So if you're an individual, a group, a virtual group, or APM entity representative, you can submit Medicare Part B claims measures, again, for groups of 16 or less, so again, only small groups. And again, this would be submitted through routine Part B claims, so you would append a quality data code, which is a CPT2 or G code to your claim that you would send in, and we would be notified of that and capture the information. When would you submit this? You'd submit it throughout the performance period. It does need to be processed by your MAC, so your carrier MAC, and received by CMS by March 1st of 2022. So we do have a 2-month run out where you can submit claims that you generate the end of 2021 can come in through the end of February 2022. You can report ECQMs if you fall into the original group of virtual group, APM, individual, or group. You can sign into the qpp.cms.gov and upload a QRDA3 file. The submission period for that is January 3rd through March 31st of 2022. So basically the first 3 months after the reporting period ends, the reporting/performance period. So basically when you're collecting your data. There's MIPS CQMs. Again, you can sign into the same app that I mentioned before and upload a QPP JSON file. Again, the first 3 months of 2022 for your 2021 data. You can also use MIPS, well, we'll talk about third-party intermediaries in a second. You can use the CMS web interface where you would manually enter your data or upload a file to the CMS web interface. And again, this is for people that register to use the web interface and have to be the larger groups. You can use the web interface application programming or interface or API. And again, this data is collected the first 3 months of following the performance period. Third-party intermediaries, so by these we mean, again, the qualified clinical data registries or qualified registries or health IT vendors. Again, you can report MIPS CQMs, electronic clinical quality measures, or QCDR measures. You can see how you would submit these, and again, it's the first 3 months of next year. CMS approved survey vendors. This is the CAHPS for MIPS survey measure, and it would be a secure method outside of the qpp.cms.gov method for submitting. And this, of course, is following data collection in terms of the time frame for when it would be submitted. I think that's it for my slides. So I'm going to turn the call over to Zenobia Raspberry to talk a little bit about scoring. Thank you.
Thanks, Dr. Greed, and good afternoon, everyone. I will be talking about the quality scoring policies for 2021. Next slide, please. So for the 2021 performance period, quality measures can receive a score between 0 and 10 points. Our policy as it stands right now is that there is a 3-point floor, scoring floor in place for measures, which means that assuming that submitted measures have a performance rate greater than 0 in the case of non-inverse measures and less than 100% in the case of inverse measures, the lowest score that you can receive is 3. So what that means is based on the level of the measure, we divide measures into class 1, class 2, and class 3 based on whether they meet certain criteria. So for class 1 measures are those that meet the data completeness requirement, meaning that 70% of the required data is reported, has a benchmark, and meets the case minimum requirement of 20 cases. These measures can be reliably scored against the benchmark and will receive between 3 to 10 points. In the event that a measure meets the data completeness requirement but does not have either a benchmark or meet the case minimum requirement, that will receive a flat 3 measure achievement points. And finally, class 3 measures, those that do not meet the data completeness requirement, regardless of whether they have a benchmark or meet case minimums, those will score a 0. However, in the case of small practices, which are defined by the program as those with 15 or fewer eligible clinicians, they will continue to receive 3 measure achievement points. As a note, these scoring policies don't apply to the CMS web interface measures or administrative claims-based measures. So for more information regarding the CMS web interface scoring policies, you can refer to the 2021 CMS web interface quick start guide, which is available on the QPP website. Next slide, please. There are some measures in the program that are identified as topped out, and I will define sort of what that standard is, and that information is on this slide. But those topped-out measures are identified annually through our benchmarking process. And measures that are topped out for consecutive years can be proposed for removal through rulemaking, though that is not necessarily the case all the time. So those standards for deciding or defining what a top-down measure are as follows. Process measures that have a median performance of 95% or higher for non-inverse measures or 5% or lower for inverse measures are considered topped out. For non-process measures, that standard is a level of variance that is greater than a 10. Less than a 10, and the 75th and 90th percentiles being within 2 standard deviations. Additionally, there is a level defined as extremely topped out, in which the average performance rate is 98% or higher in the case of non-inverse measures, and 2% or lower in the case of inverse measures. To typically, CMS considers these measures for removal in the next rulemaking cycle, even if it's in the midst of a top-down measure cycle. But they may be retained in certain cases, oftentimes in the case of subspecialties that have very few measures, or if the measure is a part of a specialty set. Top-down measures are subject to special scoring policies, namely the 7-point scoring cap, which is the case of top-down measures that are defined as top-down for 2 consecutive years, have a 7-point cap applied in the second year. So not all top-down measures receive a 7-point cap, and you can refer to the 2021 Quality Benchmarks Guide on the QPP website to see which are identified as top-down. And an additional note is QCDR measures are not subject to this top-down measure life cycle, nor the special scoring policies. Next slide, please. Quality measure performance is assessed against the benchmark, meaning that based on whichever level performance the data submitted lies in, what decile the performance lies in, they will receive that score. As Dr. Green mentioned earlier, benchmarks are established specific to each collection type, meaning that data collected all from MIPS Part B claims is used to establish a benchmark specific to, Medicare Part B submission type or collection type, Typically, benchmarks are calculated using historical data from 2 performance period prior, which means that in the case of 2021, the benchmarks are calculated from data submitted during the 2019 performance period. Data submitted from the 2019 performance period. If a measure doesn't have a historical benchmark, we will calculate a performance period benchmark, assuming that 20 different clinicians or groups report on this measure and they achieve the case minimum requirement. Next slide, please. Oh, excuse me, just very quickly, I wanted to note that while we typically use historical benchmarks, there are some measures that are scored against a flat benchmark in the case that performance against a historical benchmark would incentivize substandard care. Those measures are Measure 236, controlling high blood pressure for the MIPS CQM and Part B claims collection types, and Measure 1, diabetes hemoglobin A1C for the Medicare Part B collection type. For the web interface, CMS uses the SSP benchmarks, the Medicare Shared Savings Program benchmarks, to measure performance for groups, virtual groups, and APN entities that register to report for the CMS web interface measures. Again, these benchmarks can be listed at can be found at the listed resource. A benchmark is established for each summary survey measure in the CAHPS for MIPS survey measure. So each SSM is awarded 3 to 10 points based on performance against the benchmark, and these individual scores are aggregated to be the overall CAHPS for MIPS survey score. Next slide, please. Okay, and here we have sort of a crosswalk to sort of visualize how the benchmarks are converted to measure achievement points. So as I was sort of talking about earlier, there are certain parameters that a quality measure must meet in order to receive a score greater than 3. And the first of which is, does the measure meet data completeness requirement? If not, that will receive a 0 in the case of all practices other than small, and small practices will receive 3 points. Again, the next threshold would be if the measure meets the case minimum requirement of greater than 20 cases. And if it does not meet the requirement, they will receive a flat score of 3. If it does, we determine if there is a benchmark available. This question can sort of have a sub-question: is there a historical benchmark? And in that case, it can be scored against the historical benchmark 3 to 10 points. And the next sort of sub-question here is, can a performance period benchmark be calculated, which would require, as Dr. Green and I sort of stated previously, 20 different clinicians or groups to report a measure that meets both the data completeness requirement and the case minimum requirement. So if that is not achieved, and a performance period benchmark cannot be calculated, the measure receives a flat score of 3. But if a performance period benchmark can be calculated, it can be scored for 3 to 10 against a benchmark. Next slide, please. Okay, so I sort of spoke to this a couple times now, but so just to reiterate, in the event that a measure doesn't have a benchmark, you will not receive a 0 score, but you will receive 3 measure achievement points, unless a performance period benchmark can be calculated. And again, the policy for measures that don't meet data completeness requirements is that it will receive a score of 0, except in the case of small practices, which will continue to receive 3 measure achievement points. Next slide, please. So now I'm going to talk about improvement scoring. So for the 2021 performance year, you can earn up to 10 percentage points based on your rate of improvement in this performance period from the previous performance period. So this improvement score is calculated by comparing equality achievement score from 2021 to the previous performance period of 2020. So here in this diagram, you can sort of see the calculation here. And in the numerator, you would find the difference between performance in the quality performance category, the difference between the scores in 2021 and 2020, excluding measure bonus points, over the performance in the 2020 quality performance category. And then you multiply that score by 10% to calculate the improvement percent score. Next slide, please. So calculating the score, the quality performance category score, overall is done as follows. The top diagram shows how it's scored for non-small practices. Again, for a reminder, small practices are defined as practices with 15 or fewer clinicians. So in the numerator, we have the total measure achievement points, the total achieved measure achievement points over the measure, plus the measure bonus points over the total available measure achievement points. And we'll talk about those later on. And then that's multiplied by 100, and the improvement percent score that we previously talked about is added to that score. In the event of small practices, it's essentially the same. However, in addition to measure bonus points in the numerator, you could also receive up to 6 points of the small practice bonus. And again, that's the total achieved measure achievement points plus the measure bonus points and the small practice bonus over the total available measure points, measure achievement points multiplied by 100%. And then with the improvement percent score added. Next slide, please. So here we have a chart with the maximum points available, and those generally correspond to the reporting requirements. So if you have 6 required measures that you have to report, each one receives 10 points. So the standard would be 60 points that make up this like sort of denominator value of the maximum possible achievement points. So for individuals, we have it broken down here. It's possible to earn 60 points, which is standard, and 70 points in the case that the administrative claims measure is automatically calculated on your behalf. And that administrative claims measure is the total hip and total knee arthroplasty complication measure. For groups, virtual groups, and APM entities, 60 points is the standard, as I sort of said before, as that's the 6 required measures. 60 points is the standard maximum points available. However, if you are able to be calculated for the hip arthroplasty, knee arthroplasty measure, or the hospital-wide all-cause unplanned readmission measure, that denominator value goes up, and you'll see that in the following examples. So if one of those measures can be calculated on your behalf, meaning you meet the minimum case requirement or are a practice of greater than 15 clinicians, small practices don't have the hospital-wide all-cause readmission measure calculated on their behalf. But if you can have one of those administrative claims-based measures calculated on your behalf, you'll receive a maximum achievement points of 70. And if you can have both, that will go up to 80 maximum achievable measure points. Next slide, please. So these are the maximum points available for the CMS web interface measure, and it's a similar case, except the standard amount of points available is 70 points. So so now we have the vectors that can increase your maximum achievable measure points are the 2 administrative claims-based measures and the CAPS for MIPS survey measure. So if one of those things can be is calculated on your behalf, then your maximum achievable points goes up to 80. If 2 of those things, meaning the 2 administrative claims-based measures or 1 claims measure and a CAPS for MIPS measure, that your maximum achievable points goes up to 90. And if all 3 of those are calculated on your behalf, or can be calculated, if you reach the requirement for the CAPS for MIPS survey measure, then your maximum achievable points goes up to 100 points. Next slide, please. Okay, so for facility-based scoring, your quality and cost performance category scores will be calculated for you. If you're identified as facility-based, are assigned to a facility within the fiscal year 2022 hospital value-based purchasing program score. And your facility-based score results in a higher hospital VBP program combined quality and cost score than the MIPS quality and cost measure data we calculate for you. So what that means is essentially you'll receive a facility-based score if you meet these parameters and your MIPS quality and cost scores are lower than it would be if you were calculated as a part of the facility. Next slide, please. And finally, here we have information on the reweighting of the quality performance category. So quality performance category can be reweighted to other performance categories in the event that there are no quality measures available to you, or you submit a extreme and uncontrollable circumstance application and it is approved. So typically for the 2021 calendar year, the quality performance category is defined as 40% of the final score. However, if the quality performance category is reweighted, it receives 0% of the final score, and that 40% is largely reweighted, entirely reweighted to the promoting interoperability performance category, which would now have a weight of 65%. Next slide, please. Okay, and that is it for the scoring of the quality performance category. And now I'll turn it over to Dr. Roach to talk about the cost performance category.
Hello, I'm Jesse Roach. I am the acting Chief Medical Officer of the Quality Measurement and Value-Based Incentive Group at CMS. And we're going to talk about the cost performance category for 2021. Next slide, please. Yes. Thank you. For the 2021 performance year, the cost performance category will be worth 20% of your MIPS final score. It will be 0% for those that are participating as an APM entity, and it has a 12-month performance period from January 1st, 2021 to December 31st, 2021. Next slide, please. Cost is defined as the standardized allowed amounts of Medicare claims. CMS uses Medicare claims data to calculate the cost measure performance, and so clinicians don't have to submit any data for this performance category. This year, we will have a total of 20 cost measures available to evaluate cost category performance. There will be no new measures introduced in 2021. So they have 18 episode-based measures, the TPCC, which is the total per capita cost measure, and Medicare spending per beneficiary clinician, MSPB measure. Next slide. So for each measure is attributed to clinicians according to the measure's unique specifications. There are 2 documents that are available for each measure. You can get a measure information form, which describes the methodology used to construct each measure, and then a measures code list, which concerns the service codes and the clinical logic used in the methodology. It includes the episode triggers, which we will talk about later, and also the exclusion categories, subgroups, and risk adjusters. And then the MIPS 2021 Summary of Cost Measures provides an overview of the cost measures, their development, and estimated cost and clinician coverage metrics for those measures that we're using. Next slide, please. So the cost measures in the 2021 performance year, as we described before, total per capita cost, which measures the overall cost of care with a focus on primary care. It has a case minimum of 20 patients, and the data sources are listed there. The Medicare spending per beneficiary clinician, it assesses the cost of Medicare for provided to patients immediately around a hospital stay. The case minimum for this is 35 episodes. And then there are 13 procedural-based measures and 5 acute inpatient medical condition measures. And we'll go into those a little more depth later in the presentation. Next slide. So certain features apply to the TPCC and the MSPB clinician and to the procedural and acute inpatient episode measures. These include payment standardization. So a process of calculating standardized claim payment amounts that allow for the measurement and analysis of clinician resource use by CMS and researchers. Standardization can include several factors that we account for. So regional differences in labor costs and practices, differences in the relative price of inputs in each local market, extra payments from Medicare and medically underserved regions, and then policy-driven payment adjustments, such as those we do for teaching hospitals. We also look at attribution. So calculation of claims-based measures requires attribution, which is basically the assignment of the patient's treatment costs to the clinicians that cared for them, so that these people can be evaluated. And the attribution method will be in the measure specs, which is on the measure information form. And then risk adjustments, which are accounts for differences in patient characteristics, such as clinical risk factors that aren't directly related to the care that a patient receives, but can influence the cost of care provided. So for instance, if you see patients that have a disease that makes them more likely to have expensive care, that will be accounted for. This shouldn't be confused, though, with the complex patient bonus, which is assigned at the final score level and not at the specific measure level. Next slide, please. So now we're going to go over the 2021 cost measures specifically. Next slide. So thank you. Medicare spending per beneficiary clinician. So it assesses Medicare's Part A and B costs incurred during a single patient during an episode window. It distinguishes between surgical and medical episodes based on the diagnosis-related group, or the DRG, of the inpatient hospital admission. So these are attributed in 2 steps. First, it's attributed to the TIN that billed at least 30% of the inpatient evaluation and management services, so the EM services listed on the Part B for the inpatient stay. And then when you have a TIN, the episode is also attributed to any clinician in the TON who billed at least one EM service during the inpatient episode. Surgical episodes are done a little differently. They are attributed to any clinician who performed any related surgical procedure during the inpatient stay, and to the TIN under which the clinicians billed for this procedure. Next slide. The exclusion criteria for the MSPB clinician are patients who weren't enrolled in Medicare Part A or B during the look-back period prior to the index admission through 30 days after the discharge. So if you weren't in Medicare Part A or B before or up to 30 days, through 30 days after the discharge, you're excluded. You weren't enrolled in private Medicare health plan during the window episode or 90-day look-back period. You resided outside of the U.S. during any month of the performance year. Episodes are also excluded if they didn't occur in a subsection D hospital paid under the IPPS or acute hospital in Maryland. So hospitals that aren't included in this include psych hospitals, rehabilitation hospitals, children's hospitals, long-term care hospitals, and cancer research hospitals. Or if your episodes are excluded if there was an acute to acute hospital transfer. So transfers between 2 acute hospitals, and those episodes are excluded. Next slide, please. MSPB clinician measure is calculated by defining the population of the index admissions, and then taking those admissions and attributing them to a clinician group and then to a clinician or clinicians, excluding clinically unrelated services. So we want to make sure that things that aren't related to the care that the physicians delivered are excluded. excluding episodes that don't fit and are included in the exclusion criteria, and then calculating the expected cost through risk adjustment, so what you would expect to cost, and then calculating the measure score. So we take what was spent over what you would expect it to cost, and then calculate a measure score based off of that. Total per capita cost, or the TPCC. These measure overall costs delivered to a patient with a focus on primary care and the care they receive from the primary care physicians. So it's attributed to clinicians using 4 steps. So we identify, thank you for going to the next slide. So this is a TPCC. So identifying candidate events based on the occurrence of certain primary care services that indicate the start of a primary care relationship. So that's basically, and that's the term in the primary care relationship is determined in 2 steps. One is getting an E&M service that's associated with primary care, and then getting another primary care service within 3 days prior to or 3 days after the initial one, or getting a second E&M service within 90 days after the initial one. So applying that service category and specialty exclusions only to include specialists and clinicians providing primary care. So basically, we want to make sure it's people that are giving mostly primary care. So we do that. So if you've had 15% or more of the events or surgery services, you're going to be excluded. 5% or more of your events being anesthesia, 5% or more of your practices events being therapeutic radiation services, or more than 10% of your events being classified as chemotherapy events, you're going to be excluded. So this is trying to ensure that primary care physicians are mostly involved in this. And then constructing the risk windows during which a clinician could reasonably be held responsible for the treatment cost. These are typically a year and can straddle our measurement periods. So it could be over, So it could be over 2 different periods depending on where that 12 months happens. And then attributing beneficiary amounts that occur during the risk window and the performance to TINs and practitioners within the TINs. Next slide, please. Exclusion criteria for the TPCC are patients who weren't in Medicare Part A and B for every month of the performance year, who were enrolled in private Medicare health plan during any month of the performance year, resided outside of the U.S. for any month during the performance year, or if they are covered by the Railroad Retirement Board. Specialty adjustments are applied to the TPCC to account for cost variation among specialty or across specialties in TINs. Next slide, please. So after the attribution, the TPC is calculated via the following steps. First, the payment standardized monthly observed costs. So the standardization, similar to what we had described with the MSPP measure. We calculate the risk score. You risk adjust the costs based on, as we said, conditions that are associated with the patients that make them more difficult to care for, but aren't related to care. Then you specialty adjust based on which specialty, and then you calculate the measure score. So the numerator is the sum of the risk adjustment months, risk adjusted costs and specialty adjusted costs, and the denominator is the beneficiary months attributed to the TIN and the provider. Next slide. Of note, that is measure is expressed as a dollar amount, which is then converted to a score. The 2021 cost measures, episode-based cost measures, these are used to assess the cost of Medicare for items and services provided to a patient during an episode of care. Only include items and services related to that specific episode of care for a clinical condition or procedure. The attribution is done by this for acute inpatient episodes. It's the first TIN it's first attributed to the TIN that billed 30% of the inpatient E&M services, and then attribute it to any clinician in that TIN once you've determined what TIN is involved. And then for procedural episodes, the episode is attributed to any clinician who bills the code. That will be what triggers the episode. So calculation. So once what episode is defined, and you attribute it to the clinician, you find the cost of the episode and calculate the total observed episode costs, and then figure out which episodes need to be excluded from the calculation based on our exclusion criteria. You then calculate the expected episode cost through risk adjustment, and then you calculate the measure scores by dividing the costs over the expected costs. So these are the cost measures, and the next two slides are somewhat busy, but I will just go over them briefly, and then and these are available. I'm sorry, I didn't go to the next slide, so we can go to the next slide with the chart. Thank you. I'm sorry, I'm getting ahead of myself. So the measures that are involved for 2021, the cost measures. So the procedural measures, so we have elective outpatient percutaneous coronary interventions, knee arthroplasty, revascularization for lower extremity limb ischemia, routine cataract removal, screening or surveillance current colonoscopy, acute kidney injury requiring new inpatient dialysis. So next slide. Elective primary hip arthroplasty, femoral or inguinal hernia repair, hemodialysis access creation, lumbar spine fusion for degenerative disease, lumpectomy, partial mastectomy or simple mastectomy, non-emergent coronary artery bypass graft, renal or ureteral stone surgical treatment. Next slide. And then the acute inpatient medical conditions are intracranial hemorrhage or cerebral infarction, simple pneumonia with hospitalization, ST elevation myocardial infarction with percutaneous coronary intervention, inpatient chronic obstructive pulmonary disease, COPD exacerbation, and then lower gastrointestinal hemorrhage, so lower GI bleed, which applies only to groups. Next slide. Now we're going to discuss the scoring for these measures. Next slide. So CMS uses Medicare Part A and B claims to calculate cost scores. Performance period, as mentioned before, January 1st, 2021 to December 31st, 2021. That clinicians do not need to submit data or take any separate actions for these. It's weighted differently for participants based on what you're doing. 20% for individuals, groups, or virtual groups. 0% for APM entities. For the 2021 performance year, cost feedback and additional patient-level data will be provided in summer 2022, and then payment in summer 2023. Benchmarks, CMS calculates a single national benchmark for each cost measure based on the performance year, not a historical baseline period. All MIPS eligible conditions that meet or exceed the case minimum for a measure are included in that benchmark. Currently, CMS doesn't publish the MIPS cost measure performance year benchmarks. For a cost measure to be scored, individual group must meet the minimum. If one cost measure can be scored, the measure score will be used to compute the performance category score. If multiple cost measures can be scored, the performance score will be the result of the equally weighted averages across the measures that were qualified for. If no cost measure can be scored, costs will count 0% towards the final MIPS score. And then CMS will reweight. I'm sorry, can you go to the next slide? Sorry, I'll start over. For cost measure to be scored, individual must meet the minimum. If one cost measure can be scored, that will determine the score. If multiple cost measures can be scored, your score will be determined by the average of those, and they'll be weighted equally. If no cost measures can be scored, the costs will count 0% towards your total MIPS score. And CMS will reweight the performances accordingly, with 0% for costs, 55% for quality, 15% for improvement activities, and 30% for promoting interoperability. Next slide, please. So CMS will assign 1 to 10 achievement points to each score based on the performance according to that performance year benchmark. The score that you get will depend on which decile range you fall in. They won't include improvement scoring until the 2022 MIPS performance year, which corresponds to the 2024 MIPS payment year. For reweighting, CMS will automatically reweight the cost performance category for clinicians who are affected by the extreme and uncontrollable circumstances policy. If that happens, CMS will assign a weight of 0 for the MIPS final score, even if we're able to calculate the cost measures. If other performance categories are reweighted, the cost performance category will always be weighted at either 20% or 0%, unless there's only the cost and improvement activities are the only 2 categories score, and then both categories will receive a weight of 50%. And now I'm going to turn it back over to Dan Herman for CVS.
Thank you, Dr. Wright. Next slide, please. On this slide, we've listed additional helpful resources. We encourage you to refer to the 2021 Quality and Cost User Guides for details on these 2 performance categories for 2021. All of these resources are available on the QPP Resource Library. Additionally, CMS will post the slide deck from today's presentation to the QPP webinar library, along with the recording and transcript, if you'd like to go back and review anything. Next slide, please. Before we move to the Q&A portion of the webinar, we'd like to remind everyone of some helpful services that are available. We offer no-cost technical assistance for small, underserved, and rural clinicians who need it. We encourage you to check it out if you qualify. We also have agents available at the QPP Service Center to help answer any questions you may have, and you can reach them at 1-866-288-8292. For TRS, dial 711, or qpp@cms.hhs.gov. And finally, we have resources available on our QPP resource library, and previous webinars are posted to our QPP webinar library. Next slide, please. Now I will turn it over to Ketchum to begin the Q&A.
Great, thank you, Dan. Okay, so for the Q&A portion of the webinar, you may ask questions via chat or via your phone. To ask a question by the phone line, please dial the number on your screen. It's 1-833-376-0535. And if prompted, you can provide the conference ID 4875638. You may need to press *1 to be added to the question queue. Please note today's webinar our Q&A portion will only focus on MIPS quality and cost performance categories for the 2021 performance period. For other questions, of course, you can contact the QPP Service Center. Okay, so we can get started with a few questions. First one is a quality question that asks, if a performance period benchmark is a performance period benchmark calculated for that year using that year's data, and would it then be considered a historical benchmark?
Hey, so
go ahead. Oh, sorry, didn't mean to cut you off, but this is Anovia Raspberry. I just wanted to address the question. And if you have further questions, please feel free to jump in afterwards. But in the case of performance period benchmarks, yes, they are calculated with that year's data. So in the case of 2021, if a measure receives a performance period benchmark, it will be calculated from data submitted from the 2021 performance period. And for the follow-up question, yes, it would be considered for the historical benchmark for use in 2023, if that was what that meant. But yeah, I'll stop there.
Great, thank you. Okay, your next question also pertains to the quality performance category and asks, how does CMS know if a measure meets the data completeness criteria?
So I guess it really depends on the collection type in which you're reporting. So for data completeness, you would want to include all those in your eligible patient population. And CMS does work and collaborate with the third-party intermediaries, such as the qualified registries and QCRs, to ensure that the data submitted is complete, accurate, and true. So that's one way. And then I know that from the claims perspective, there is some based on the eligibility of what is submitted on the claim will factor into the data completeness. So depending on the collection type, you'd want to make sure that you at least report 70% of that eligible patient population. And I know there's a lot of questions in the Q&A that were referring to how to calculate. So I would encourage folks there are flows that do provide sample calculations for each of the different collection types. So I'd encourage folks to look at those and just see how that is calculated.
Great, thanks for that. All right, Shelby, are there any questions on the phone line?
No, there are no telephone questions.
Okay, no worries. We can stand by for more. Again, to ask a question, you can dial the number on your screen. Okay, next is a cost question. We're asking for clarity on what payment standardized includes and what payment standardized means. Could you please clarify that?
Sure, I can speak to this question. This is Joyce Lamb. I'm from the cost team. So payment standardization is the process of adjusting the allowed charge for a Medicare service. And the purpose is to facilitate comparisons of resource use across geographic areas. There are a set of specific updates that payment standardization applies. So it preserves the differences that result from healthcare delivery choices, such as the setting where the service is provided, the type of healthcare provider, but it excludes geographic differences, for example, due to regional labor costs and practice expenses, and these are measured, for example, through hospital wage indexes and geographic practice cost indexes. It also excludes payment adjustments from particular Medicare programs that are not directly related to resource use for the service, such as graduate medical education and indirect medical education, disproportionate share payments, value-based purchasing payment adjustments, and other such adjustments under programs. And by making these adjustments, we are able to come to a payment standardized amount, also sometimes referred to as price standardized, where the national amount that we use for payment standardization allows for a comparison of resource use across geographic areas.
Great, thank you. Okay, next we have a quality question that asks, do you have to opt in to the administrative claim measures?
Sorry, no, you don't.
Great, thank you. Okay, next, again, another question on benchmarks. This question asks, why do some measures that have had benchmarks for years no longer have one for 2021, for example, measure 317, while this measure has been around for many years?
Yeah, great question. So for this particular measure, the frequency actually went from once per performance period to every visit. When there's a substantive change that may impact the benchmark, benchmarks will be removed, and if there's sufficient data that is captured in that year, a performance period benchmark will be created. I will point you to the 2021 final rule, and within that, we call it the D tables. It will outline and call attention to those substantive changes that will no longer allow comparison to the historic benchmark, and that in those instances, the benchmark would be removed.
Great, thank you. All right, Shelby, do we have any questions on the phone line now?
Yes, you have a question from Rosalind Lowry of CareK Value-Based. Sorry, I missed the rest of her company name. Please go ahead, Rosalind.
Yeah, hi. I have a questions about QCDRs. In particular, let's say it's a registry that only offers 7 MIPS-based measures. GI Quick, for example, is one I work with pretty frequently. And about half those 7 measures that are available to report for MIPS don't have benchmarks. In that case, would this QCDR fall under the same category as specialty groups with less than 6 available measures? Or would the group I work with need to look to different reporting methods like claims or potentially finding less appropriate measures through their EMR?
So I think I need to understand your question a little bit more, and Dr. Green, you might need to jump in here. But so it's a QCDR that has QCR measures, and they don't have benchmarks.
They have 7 MIPS applicable measures, and only about 3 or 4 of them actually have benchmarks. The rest don't, so they're only eligible for the 3 points because it's a small group.
Yep.
So are they? Sorry. I was just going to ask, are they QCDR measures, or are they in the MIPS part of the 200 plus MIPS measures?
They're QCDR measures.
Go ahead, Jocelyn, unless you want me to take it.
I was going to say, I'm thinking in this instance, they would need to report the 6 measures. And as we have been saying, definitely encourage, we're looking for QCRs to encourage those clinicians and groups to submit those measures, as they will make that performance period benchmark, which would then qualify, for more points if applicable. But Dr. Green, do you have anything else to add?
Yeah, so I think just to elaborate a little bit on what Jocelyn said, as I mentioned before, we require 20 clinicians and/or groups to report on at least 20 instances of the measure. So, if you guys do with your group of docs, and especially if you're reporting individually, and however many others, once we get a quorum of 20, again, with the right number of cases, we can create a performance year benchmark. So in other words, we can use that data to actually calculate a benchmark, and then those clinicians who reported it would be able to, have access or earn the additional points above the 3. But unfortunately, there's no guarantees because we don't know. You guys may be dissuaded from reporting that measure or those measures, and others may be in the same boat saying, oh, we don't want to be stuck with 3 points. But if nobody reports them, we'll never even be able to get up to a performance benchmark. So it's a little bit of a roll of the dice for you guys, but that's where we are.
Okay, so our best bet would be to report those measures and then also start reporting ASAP through another method, just on the off chance that the 20 quorum isn't met.
Yes, that would be a good idea. The other thing you could do is you could talk to the QCDR and just say, hey, we're willing to report these. We have, 4 practitioners, and each one has more than 20 cases. Do you have other docs that are planning to report this measure so they might be able to benchmark it? Again, they're not going to be able to guarantee you either, but at least you could get a sense like, no, you're the only 4 that are interested in reporting it, or hey, we've got a whole bunch of people that are in the same boat. We'll try to encourage everybody to report it, and then it'll be benchmarkable.
Okay, thank you.
Thank you.
There are no other telephone questions.
Great, thank you. Okay, your next question is another quality concern, and it asks, if a specialty measure set contains more than 6 measures, is it true that participants still only need to report on 6 measures?
Yes. Please do make sure that one of the measures is an outcome measure at a minimum. And if there are no outcome measures available in that specialty set, make sure you please report one of the other high priority areas.
Okay, great. All right, next we have a cost question that asks, if we do not report because of the COVID extreme and uncontrollable circumstances of application, can we still receive cost feedback for 2020 or 2021 for informational purposes?
I am not sure about that one if we'll be providing feedback. Can we respond to that later?
Yes, of course. We can come back to that if needed. Okay, next, how would a specialist measure quality when there are no follow-up appointments?
So I think not all measures require follow-up appointments. So I would look at any of the quality measures and see what would be applicable and fit within their clinical workflow. So my first recommendation, just to peek there, if not, the quality team is more than happy to help you find meaningful quality measures that would fit into your workflow.
Great, thank you. Okay, next, why were all of the opioid quality items removed from this year?
Was that opioid? Is that what you said? I think that's okay. So I think the question was, why were all the opioid quality items removed this year? So in the 2021 final rule, you'll see the rationale for removal indicates that the measure steward did not want to continue updating the measure, citing that there are newer, more opioid measures to report that are not topped out. This does remain as one of CMS's priorities. So again, if there are measure developers out there that wish to submit a measure addressing the opioid topic, we do encourage those quality measures to be submitted to the call for measures, but unfortunately, those three measures were retired for 2021.
Great, thank you. Do you have any other questions on the phone line?
Yes, you have a question from Carmen Wilson of Palmetto Orthopedic Clinic.
Hi. When it comes to doing the cost measures, we're an orthopedic group, and I know that there's the hierarchical condition coding. Where can I find information about that to kind of set off that risk assessment? I've tried looking on the in the QPP library. I've reached out to my local group that can help small practices, but I'm trying to find out how we go about recording that information, since we are specialists and they have comorbid conditions that can offset our cost factor. How do I record that, or can you guide me where I find information about that?
Sure, we can follow up with some links. So just to clarify one point though, you don't need to do anything in particular for risk adjustment. So the risk adjustment is calculated automatically using information in a patient's claim history. So for the episode-based measures, we use a 120-day look-back period. So in the 120 days prior to, say, the orthopedic procedure being performed, we'll look at all the Medicare claims in a patient's history, and then based on the diagnoses that we see there, we will run the HCC algorithm, which will then identify particular flags for comorbidities, conditions, patient risk factors that could affect the costs. So you don't need to do anything in particular for that coding.
And so when you say all the Medicare claims, that's regardless of what physicians the patient saw in that 120 days prior to the procedure?
That's correct. So we'll just look at the universe of claims.
Okay. we were told that we had to make sure we added those diagnoses to our preoperative claims submitted to Medicare so that it reflected that we were aware of those diagnoses. But you're saying we don't have to do any of that at all because you automatically look at it and it's all taken care of based on the universal claims that are submitted, and then you run the algorithm to determine the cost factor for us.
That's right. It's a model that is calculated automatically. So, and I'm obviously the decision of what diagnosis to code is a separate question for when it's appropriate to code that. But for the purposes of risk adjustment, we don't need any particular information beyond what is automatically included in the claims.
Okay. And is there an article that I can read further information about the coding if I wanted to? Is there a good link to follow up that, being a specialist on reading more information about that?
There's, beyond the measure specifications documents, there is the actual HCC mapping. It's publicly available. It's a CMS model. So we can follow up with some links.
That would be wonderful. Thank you so much for your time.
Yep.
Okay, well, we have time for about one or two more questions. So we do have a question that asks, how are the quality measure bonus points calculated? I can repeat that. The question asks, how are quality measure bonus points calculated?
Quality measure bonus points are awarded based on, there are two types. They are high priority measure bonus, and there's an end-to-end reporting bonus. In the case of the high priority bonus, clinicians get 2 measure bonus points for every high priority measure that is submitted beyond the one required high priority or outcome measure. I believe that the distinction is that outcome measure receives 2 points and other high priority measures receive 1 point. And if that's wrong, someone can correct me. In the case of the end-to-end reporting measure bonus, clinicians receive 1 point for each measure that is submitted via end-to-end electronic reporting. I'll stop there.
Okay, great. Thank you. Okay, well, that actually wraps up all the time that we have for questions. So I'll pass the webinar back to Dan Herman to go ahead and conclude.
Great. Thank you. Thank you all, and thank you for your questions today. We hope this helped provide an overview for participating within the quality and cost performance categories of MIPS for the 2021 performance year. We encourage you to download materials from the QPP resource library for more information. You can also sign up to our listserv at qpp.cms.gov to remain updated on news and announcements. Finally, the slide deck, recording, and a transcript of today's presentation will be posted to the QPP webinar library in the next few weeks. Thank you again for joining, and have a good day.
Ladies and gentlemen, this concludes today's conference call. Thank you for your participation. You may now disconnect.